Okay, well, it is 1 o'clock Eastern Standard Time by my watch. So, out of respect for all those who were able to make it on time, I think we will get started. Good afternoon, ladies and gentlemen. I am Dr. Joseph Demellawy. I practice as a pediatric pathologist at the Children's Hospital of Eastern Ontario, the CHIO, in Ottawa. I am also chair of the Pathology and Molecular Diagnostics Cluster at the Pediatric Oncology Group of Ontario, the POGO, in Toronto. Now, on behalf of the Pediatric Oncology Group of Ontario, the Canadian Partnership Against Cancer, and the Canadian Association of Pathologists, I would like to welcome everyone to today's CAP Cancer Protocol Education session on pediatric patients with hepatoblastoma. I will be the moderator for today's webinar. Now, before I introduce our speaker and we can get underway, I would like to take care of a few housekeeping items. First, this session is being recorded. Yes, please be aware this session is being recorded, and the link to the recording on CancerView will be circulated to all participants via email once it becomes available. The CancerView website will be upgrading over the next few months. One of the first upgrades is that the CAP education session recordings will now be available on YouTube. We will share the direct YouTube link to this session, as well as the link to the CancerView page when you call, where you can review all your previous sessions when you contact. 2, both the live presentation and the recorded presentation are eligible for CME credits. Information for obtaining the credits can be found in your session notice. Please note that the CME certificates for each of the education sessions will only be issued for 1 month from today's date, the date of the presentation. So please refer to the session notice for the exact deadline date. 3, please note that everyone's line has been automatically muted for today's presentation. 4, we have a large number of participants, and so we would not be able to troubleshoot Skype for Business issues as part of this call. If you are experiencing technical difficulties, please call the Skype for Business support line. We encourage you to submit questions at any time during the presentation using the chat feature within Skype. Chat instructions can also be found in your session notice. 5, during the question and answer period after the presentation, I will be submitting the questions. I will be reading the submitted questions on your behalf as long as time permits to the end of today's webinar and in the order in which they appear. So if you have a question, then in the chat window, please include the following information: your institution's name, the name of the individual posing the question, and of course your question. And now it is my pleasure to introduce Dr. Dina Demellawy. Dr. Dina Demellawy is a pediatric pathologist in the Children's Hospital of Eastern Ontario, and she is an associate professor at the University of Ottawa. She has completed her anatomical pathology residency at the University of Toronto and her pediatric pathology fellowship at the University of Pittsburgh Medical Center. Dr. Demellawy is appointed at the Children's Hospital of Eastern Ontario Research Institute as a clinical investigator. She has contributed to quite a few book chapters. She has over 80 peer-reviewed publications and over 70 abstracts and publications and presentations in national and international meetings. Her main clinical and academic interests are perinatal pathology, as well as pediatric GI and bone pathology. Now, she is also the acting chair of pathology and laboratory medicine, the steering committee, and she is a current member of the archives committee on the International Society of Pediatric Pathology. She also serves on the residency pathology committee at the University of Ottawa, and she is a member of the faculty engagement committee at the University of Ottawa, as well as sits on the faculty wellness program advisory committee in Ottawa. She has held several positions in the past, including director of immunohistochemistry at William Osler Health Center in Toronto, and she was also director of the histology laboratory at Health Sciences North in Sudbury. But I guess we didn't gather here today to hear me, so without further ado, for today's talk on hepatoblastoma, I give you Dr. Dina Demellawy.
Thank you, Dr. Denancy, for your kind introduction. So I have no financial relationship to disclose, and I will not be discussing label use or investigational use in this educational session. The protocol we'll discuss today is the hepatoblastoma CAP protocol that get posted on the CAP website on February 2019. The authors of this protocol are Dr. Rudzyński, Dr. Ranga, Dr. Hicks, and Kim. This protocol utilizes the Children's Oncology Group Staging System. This protocol is intended for reporting of hepatoblastoma only and is not intended to be used for other primary hepatic tumors, so not to be used with hepatocellular carcinoma or other hepatic tumors. The most updates that came on the 2019 protocol compared to the previously used one in 2016 is that the protocol got separated into resection and biopsy. Previously, in 2016, there was one protocol that covers both biopsy and resection, but on 2019, there is two separate protocols, one for resection, one for biopsy. Because of the time limitation during this talk, I'll go over the resection protocol, but I'll highlight those items that as well are present in the biopsy, because the resection protocol have all the items that's present in the biopsy, but additional parameters. So I'm going through the resection, but highlight those parameters that are also present in the biopsy protocol. The main objective is to review the hepatoblastoma CAP protocol and its use by pathologists specializing in pediatric oncology. In the coming few slides, I'll just speak about tissue handling and the specimens that the pathologist will receive. It's just this introduction I feel is important before we start to go through the actual parameters that are present and required to be reported in the CAP synoptic reporting for hepatoblastoma. So as with any pediatric tumor, the expectation is to receive the tissue fresh. So whether the biopsy is taken by the interventional radiologist or the surgeon, the expectation is to receive fresh tissue. As with any tumor, priority is for histology. So the priority will be given for formalin. The second priority is for SNAP freezing for molecular studies. Ideally, we want to SNAP freeze at least 1 gram of tissue. However, it's a common scenario that the pathologist will receive a limited biopsy. In these cases, as minimum as 100 milligram of tumor will do. Hepatoblastoma is one of these tumors that is very rare, but more important, it tends to display different histological features. And these features and patterns may impact the patient treatment and outcome. So it's recommended to grossly SNAP freeze different tumor regions that look grossly different. For each of these foci, a corresponding section should be taken for histology and should be appropriately identified. It's also mandatory by the COG protocol to SNAP freeze normal-looking liver, as well as for histological examination, background liver should be sampled, for example, in cases of resection. As per the COG protocol, sterile tumor tissue that's viable is recommended or is mandatory to be submitted for cytogenetics. No normal liver or liver that's not involved by the tumor is mandated to be submitted for cytogenetics. These pictures are just showing photographic map of sections taken from a case of resection for hepatoblastoma. Mapping and detailed gross description are very helpful, especially when dealing with post-chemotherapy resections, as the tumor may be, majority of it may be necrotic. So this mapping helps the pathologist to target areas of interest. Also, it helps the pathologist whenever he or she wants to take additional section to come back and identify the area of interest to take more sections. It also ensures adequate sampling of margins, particularly in lobectomy specimens in which the margins can be quite wide and big, and also ensures adequate sampling for hilar and caval margins in cases of liver explant specimen. So the pathologist can receive the specimen in different forms. So the first question, is cytology sufficient, or can cytology be used for diagnosis of hepatoblastoma? And the answer is no. And the reason for that is that hepatoblastoma display the spectrum of patterns and morphology that can be on one end very benign looking and very deceiving, that the morphology can even overlap with normal liver, and benign hepatic proliferation and regenerative lesions. So we cannot tell within these cases the difference whether it's hepatoblastoma or a benign lesion or even normal. On the other end of the spectrum, hepatoblastoma can be looked pleomorphic, that it overlap with other tumors like hepatocellular carcinoma. So cytology cannot be used because it cannot differentiate between hepatoblastoma and all these other entities. The second question is, there is a room for frozen section in diagnosis of hepatoblastoma. So as a rule, frozen section should be avoided, and the excess tissue is better to be taken for snap freezing and for molecular studies. The only room for frozen section is that when its result will alter the operative procedure at the time of operation. For example, if the surgeon not sure about status of margin, he can send and request for frozen section. But to send tissue to make a diagnosis of hepatoblastoma by frozen section is certainly not recommended at all. If the surgeon or the interventional radiologist not sure that the tissue they are collecting is viable or necrotic, the pathologist is advised to do touch imprints just to report viable tissue or necrotic tissue. The pathologist is not required to give a diagnosis on touch imprints. So with cytology not being appropriate specimen for diagnosis of hepatoblastoma, the two procedures left will be biopsy and resection. The COG standard is to do upfront resection whenever feasible. So ideally, whenever the patient is at low stage, like stage 1 or 2, to do upfront resection. But for these cases in which upfront resection is not possible, for example, many of the cases that have multifocal disease, or cases in which the tumor involved a major vessel like the inferior vena cava, portal vein, or hepatic veins. Or if the patient presents with high stage like stage 3 or 4 disease, then upfront resection is not possible. Then the patient would undergo a biopsy prior to any chemotherapy. The reason for the biopsy is to capture viable epithelial components that are representative of the tumor prior to any effect or prior to any effect of chemotherapy alteration that can be induced by chemotherapy. One thing to keep in mind that biopsy do not upstage the patient. So in contrast to other pediatric tumor, for example, in Wilms tumor, biopsy upstage the patient to stage 3. This doesn't happen in hepatoblastoma. Biopsy do not upstage. Pathologists can receive two types of biopsies, either image-guided core biopsies or open biopsy. Whether the biopsy will be taken by interventional radiologist or the surgeon, this is a decision that's made by the surgeon and the treating oncologist. It should be noted that image-guided biopsies are adequate to make the diagnosis of hepatoblastoma and to triage as per the COG protocol, provided they meet adequacy, which means that we receive 5 to 10 cores of viable tumor tissue. It's also things to keep in mind that when we have a hepatoblastoma that extends beyond one lobe of the liver, then the expectation is to receive more than one sample. Each sample should be labeled where it is from. And the reason for that, because as the tumor grows bigger, there is higher chance that there will be variable epithelial components, and we're trying to capture all these epithelial components, particularly those ones that can have a chemo-resistant clone as a small cell undifferentiated component or a pleomorphic component. It's also mandatory or highly recommended when doing a biopsy to sample the adjacent non-tumor liver, and the tissue from this will be submitted for histology, but as well for snap freezing. And the reason for that, because it helps to understand the pathogenesis of hepatoblastoma. So the COG encouraged to sample adjacent non-involved liver to the tumor. And certainly with the image-guided biopsy, this is feasible. If the interventional radiologist see areas of calcification, or if the surgeon find hard areas, there is no need to sample these areas because they are mostly will represent a mesenchymal component, and mesenchymal component is not associated with poor prognosis and do not in most times have impact on the patient coming therapy. However, the pathologist is encouraged to correlate with the imaging findings. So if the pathologist see there is bone formation and what he or she have on their slides is only epithelial component, maybe they can add a comment that although what I have is all epithelial, the hepatoblastoma may represent a mixed pattern with a mesenchymal component bone as noted per imaging. The second type of procedure, which is the rule, which is the policy of the COG, is to do resection whenever feasible, will be resection. We have three types of resection that the pathologist can receive. Initial resection means that the tumor got resected without any prior chemotherapy. This is certainly for those patients who are stage 1, who at presentation are stage 1 or 2 disease at the time of presentation. The other type of specimen is delayed resection, meaning when the patient presents with high stage, like stage 3 or 4, they will receive there will first be the biopsy, right? And then they will receive the chemotherapy, and when the tumor shrink and perhaps the patient become resectable, then it will be followed by a delayed resection. So these specimens will show tumor but with the effect of chemotherapy. So the biopsy in these patients have the superiority that it shows tumor without the effect of chemotherapy. So it shows what's really the patient has, provided that it was extensive and able to capture different patterns of the tumor. The third option is to do orthotic liver transplant. And liver transplant is one of the procedures that can be used for resection and treatment of hepatoblastoma. The surgery procedure decision depends on pre-text and post-text, which are two systems that measure the tumor extension, one pre-chemotherapy, so pre-treatment, and the post-text after chemotherapy, usually after second dose of chemotherapy. The other things that the surgeon use to decide on the procedure is the tumor size, multifocality, presence or absence of gross vascular invasion, like IVC invasion or portal vein or hepatic vein. Obviously, when these are present, the tumor most likely wouldn't be able to be resected up front. Levels of alpha-fetoprotein are taken into the account, and as well the expectation whether the preoperative chemotherapy may change an unresectable tumor to become resectable. This is obviously done in view of what the biopsy shows. And also according whether the hepatic disease shows surgical and histopathological criteria that meets the requirement for liver transplant. So for example, as a general rule, when there is at the time of presentation metastasis, this is a contraindication for liver transplant. Whatever the type of resection that the patient underwent, it's very important to do extensive sampling to capture as much as possible different epithelial pattern, particularly so we can capture if there is a therapy-resistant clone. So as a general rule, with any tumor, that at least 1 centimeter, one section per 1 centimeter of the tumor greatest dimension will be submitted. Also, each major nodule sections should be taken from, and if the smaller nodules of the tumor show different gross morphology, then the representative sections will be taken from. Uninvolved liver, background liver should be sampled, resection margins should be sampled, and any gross positive involvement by the tumor to a major vessel like the portal vein, hepatic vein, IVC has to be confirmed microscopically. So now we're starting the parameters that present in the care protocol. So when we're dealing with the biopsy hepatoblastoma protocol, we'll see what's under the biopsy will be core biopsy, incisional biopsy, because these are the expected biopsy. There is always other, because there may be scenarios different biopsy than that. And then if dealing with the resection protocol, there will be the types of surgeries that can be done. So there will be the lobectomy, extended lobectomy, segmentectomy, and close to the end of the presentation, I'll go through a few slides to make us as pathologists familiar what are these specimens and how to interpret them. Also under resection, there is explanted liver, and as I mentioned, it's one of the type of specimens that may be received in treatment of hepatoblastoma. The next parameter will be tumor site, and this parameter is required whether we're dealing with a biopsy or a resection. And the site will be according to what the surgeon or the interventional radiologist labeled the specimen with. So right lobe, left lobe. So we'll put it. If I have a wide resection and able to assess which segment is the tumor in, or with the help of the surgeon, then we'll specify the site accordingly. The next parameter will be tumor size. This is required to be reported on resection only. The greatest dimension is recorded, but also the other two additional dimensions. If the specimen do have more than one nodule, then the 3 dimensions will be recorded for each nodule. The next parameter will be tumor focality. Whenever we see this plus sign, it means it's optional. Though optional is very highly recommended. This tumor focality is a parameter that's required to be recorded whether we're dealing with a biopsy or resection. Hepatoblastoma generally is a solitary tumor. However, in some cases, it may be multifocal, though this is less common. Multifocality could be one of the contraindication of upfront resection. The next parameter in the CAP protocol is macroscopic extent of tumor, and this is again optional, as we can see the plus sign here. And it's basically saying whether the hepatoblastoma is confined into the liver or extended to next door organs at the stomach, diaphragm, abdominal wall, and it's also capture if there is intraoperative tumor spill or tumor rupture. One thing to keep in mind that tumor spill upstage the patient, but only to stage 2. Other tumors, other pediatric tumors, like Wilms tumor, for example, it will upstage to 3. Hepatoblastoma, it upstage to 2. The next parameter in the CAP protocol will be the histological type, and this is required to be reported on whether dealing with biopsy and resection. This is one of the busiest slides I have in this talk, and it just give you an idea of how many patterns and how diverse hepatoblastoma can be. It have very many different patterns. And this is, in my opinion, the most challenging part for the pathologist to identify the pattern, but moreover, the pathologist is required to state the percent of each pattern. So how much this pattern is present in the tumor. So each pattern identify and the percent of it separately. In general, hepatoblastoma is divided into 2 types, an epithelial type and a mesenchymal type. The epithelial type includes 6 main patterns. Fetal pattern, well differentiated, mitotically inactive. The next pattern is fetal pattern, crowded, mitotically active. The third pattern is empyrion pattern. The fourth pattern is pleomorphic pattern. The fifth pattern, macrotrabecular pattern. And the sixth pattern is small cell undifferentiated pattern. The other type of hepatoblastoma is mesenchymal type, and this is divided into those with teratoid feature and those without teratoid features. There is also a type of hepatoblastoma that's called hepatoblastoma treated. This option is only present in the resection protocol. It's not present in the biopsy protocol for obvious reason, because biopsy is taken up front prior to any chemotherapy. So it doesn't exist in the biopsy. The next item is hepatoblastoma other, because there are other patterns that are not captured above. For example, there is cholangioblastoma pattern, one of the epithelial patterns, but not included here. If encountered, it can be added over here. The last type on the histological type is hepatocellular neoplasm, not otherwise specified. These are tumors that are very rare and very challenging. It's when the pathologists see a hepatoblastoma but with overlapping features with hepatocellular carcinoma. This tumor, by definition, at least the majority should have strong beta-catenin nuclear staining, and when dealing with this tumor, I suggest or highly recommend that you will be sent for COG reviewer, because they are very challenging cases. This figure that have been adopted from Dr. Feingold publication in 1983, it shows the prevalence of types of hepatoblastoma. The most common prevalent type of hepatoblastoma is the epithelial type, mixed embryonal and fetal pattern. In Dr. Feingold publication, he states it's 67% according to the number of cases he and his group analyzed. It's now with bigger series, it shows that the mixed embryonal and fetal actually account for 85% to 90% of cases. So it's the most common and the most prevalent. The next prevalent histological type for hepatoblastoma is to have a mixed epithelial and mesenchymal type, which accounts for about 20% of cases. Pure fetal type, which is the older name, now it's called well-differentiated, mitotically inactive fetal pattern, account for about 4% of cases. And the small cell undifferentiated account for only small subset of cases that doesn't exceed 5%. Through the coming set of slides, I'll go through each pattern and describe the histological findings in. So we're starting with the well-differentiated fetal type, the mitotically inactive. Previously, it was called pure fetal type. So as we can see, the tumor is formed of this, have a trabecular arrangement, usually 1 to 2 cell thick. It tends on low power to display dark and light areas or pattern, and this difference is due to the amount of glycogen content that's variable in the tumor cells. On medium power, the cells show perfectly round nuclei. We can see the uniformity of the cells. We can see that the tumor have still ample amount of cytoplasm. However, compared to normal fetal liver, there is a bit of increased nuclear to cytoplasmic ratio. On higher power, the cells nuclei are perfectly round. They don't exhibit mitotic activity. I mean, the hardest, or it's acceptable to have up to 1 mitosis per 10 high power field. Any amount above this, meaning that if we have 2 or more mitosis per 10 high power field, then this is not a well-differentiated fetal pattern anymore, and the diagnosis should be changed into crowded fetal pattern mitotically active. We can also appreciate that we don't see any nucleoli, and also the nuclei are not overlapping, so they are really nicely spaced and not overlapping. When we move to the next pattern, which is called epithelial type crowded fetal pattern mitotically active, and as the name describes this pattern, we can see that it shares with the well-differentiated is that the tumor cells are polygonal. They have perfectly round nuclei. However, the nuclei tend to overlap in some areas, a feature that was not present in the well-differentiated pattern. We can see that some of them do exhibit indistinct nuclei. The tumor in crowded fetal type do share with the well-differentiated that it can have a trabecular arrangement. The crowded fetal type mitotically active can have mitotic activity, and any mitosis that's 2 or more per high power field is a feature of is not a feature of well-differentiated fetal type, but can be a feature of the crowded fetal type. As I mentioned, both fetal types can have a trabecular arrangement, maybe 2 or 3 cell thick as in here, and extramedullary hematopoiesis can be present. It doesn't differentiate between normal liver or hepatoblastoma. In fact, the next pattern that we'll speak about, empyrion pattern, can have as well extramedullary hematopoiesis, though less common. With a well-differentiated fetal pattern, in some cases we can even identify some bile production, though not a common feature, but it can be present. Now we're moving to the next pattern, and as we can see from this image, we have a tumor, a hepatoblastoma, but we can appreciate that the lower part of the picture display a more pink morphology compared to the hyperchromatic and dark upper part of the picture. And this is basically because the lower part represents a crowded fetal pattern with transition into empyreonal pattern. So the upper part is empyreonal pattern, while the lower part is the crowded mitotically active fetal pattern. This is the common scenario, to have this mixture and this transition and this close intermingling of the tumor cells. On closer look on the empyreonal pattern, the cells tends to show high NC ratio. They have prominent nucleoli, but the very important feature is that the nuclei is no longer perfectly round, and we start to have this oval cells, angulated edges, a feature that was not present in the fetal type. Empyreonal pattern tend to show more amount of mitosis and more increased mitotic activity compared to the fetal type. The empyreonal pattern can be arranged in rosettes, as we see here. It can be also arranged in solid masses. The next pattern is the small cell undifferentiated, and when we look here, we have maybe crowded fetal, we're going to more angulated, so starting to have embryonal, but then there are these foci of relatively lighter cells. These are islands of small cell undifferentiated type. Small cell undifferentiated type can occur in two different settings. It can, the commonest scenarios to identify it as small islands intermixed with other components, whether fetal and embryonal, as seen here, like small cell, small cell, small cell. But it also can be, in some cases, particularly in young infants, can be identified to represent the entire biopsy or a significant portion of the biopsy, showing this morphology. In these cases, it's very important to do immunohistochemistry for INI and to exclude the presence of rhabdoid tumor. Rhabdoid tumor cells looks very different than small cell undifferentiated, as they display eccentric pink cytoplasm. They tend to have prominent nucleoli and have cytoplasmic inclusions that are PASD positive. When rhabdoid tumor is associated with a small cell component or in an otherwise typical hepatoblastoma, or exclusively form the biopsy, in these cases, as I mentioned, they occur during infancy and are associated with poor prognosis. The classic rhabdoid tumors show loss of INI1 staining due to INI1 gene mutation and are treated with a different protocol, treated with the MRT protocol. So the commonest scenario actually is to have the small cell undifferentiated component as these indistinct islands that are highlighted by the red arrows. On closer look, the tumor cells looks smaller relative to the surrounding embryonal and fetal type. Their size is around 5 to 10 microns, so they are comparable to a lymphocyte in size. They tend to have high NC ratio, very little amount of cytoplasm that tend to be amphiphilic. The nuclei looks uniform and have fine open chromatin. So compared to the surrounding fetal or embryonal patterns, the small cell undifferentiated looks like these pale areas because of the fine chromatin. In contrast to what's expected with such pattern like the small cell undifferentiated that may be linked to poor patient prognosis, there isn't much of mitotic activity that can be seen in the small cell undifferentiated component. The next pattern is the macrotrabecular pattern. This pattern is an architectural pattern. It's not a cytology pattern. What I'm trying to say is that the cells forming this pattern can resemble embryonal or fetal. Here they more resemble a fetal type, but it's classified as macrotrabecular based on the architecture. If the cell arrangement in the trabeculae is more than 5 cell thick, then this is a macrotrabecular pattern. Originally, when it was described, the recommendation was to call it macrotrabecular when the cell thickness exceeds 20, become 20 or more cell thick. So the trabeculae are very thick. However, further revisions came to the definition to make it just more than 5 cell thick, and the reason for that because the presence of 20 or more thick trabeculae is kind of unusual to be identified in hepatoblastoma, and is thought that maybe a subset of what originally described with this 20 cell thick can actually represent hepatocellular carcinoma. This pattern may be associated with poorer prognosis or with worse prognosis compared to the embryonal and fetal type. It's one of the rare type, and certainly any of these patterns that we are encountering, we have, whenever identified in a biopsy or a resection, we have to estimate the percent of this pattern corresponding to the whole tumor. The last epithelial pattern is pleomorphic pattern. This is when the hepatoblastoma cells start to display this atypical morphology. They start to show this eosinophilic ample cytoplasm. They certainly show some pleomorphism. They show prominent nucleoli, brisk mitotic activity, and with this pattern, actually, the pathologists may question, is it hepatocellular carcinoma or pleomorphic pattern of hepatoblastoma? This pattern usually, most commonly, if encountered, will be encountered on post-chemotherapy resection specimen. Very rarely it will be encountered at those biopsies that are made up front. One thing that may be helpful for the pathologist is that sometimes this pattern will be mixed with other more classic embryonal and fetal patterns, and this will help the pathologist to know that is hepatoblastoma. This pattern is suggested to be associated with poor patient outcome. Now we're moving to the other type of hepatoblastoma, which is the mesenchymal type. There are two types of mesenchymal hepatoblastoma, those with teratoid features and those without teratoid features. With those without teratoid features commonly, they can have osteoid or bone-like forming material as shown here. Or they can have cartilage, or they can have muscle as rhabdomyoblasts. The presence of mesenchymal component do not affect the patient prognosis. The commonest is to see this osteoid-like material, which is formed of collagen. However, the intervening cells between the osteoid are EMA positive epithelial cells, so they have nothing to do with osteoblasts. Sometimes, especially in a biopsy, the radiologist, and I mentioned that at the beginning, may see evidence of calcification or ossification because of the presence of these osteoid areas. In these cases, this osteoid may not be biopsied in or captured in the biopsy, particularly with core needle biopsies, and the pathologist can put a comment when they see the presence of calcification or bone formation in the tumor on radiology, that perhaps what they see as epithelial represent a mixed mesenchymal and epithelial based on the presence of this bone formation on radiology. Just as a comment, just this correlation is encouraged, and as I mentioned, the mesenchymal type does not impact the patient prognosis or treatment. The next type is when we have a mixed when we have a mesenchymal hepatoblastoma, mesenchymal with teratoid features. Originally, teratoid features have been used to describe presence of the glands, like particularly intestinal glands, squamous epithelium, melanocytes, or neural tissue. But now it's revised to be limited to presence of primitive neuroectodermal rosettes or retinal pigment. The presence of, when dealing with hepatoblastoma with teratoid features, particularly if it's overwhelming, if majority of the tumor looks like that, and particularly with a limited biopsy, one should keep two things in mind. First, if the majority of the tumor or all the tumor looks like gland, just something to keep on the back of our minds, that yolk sac tumor can occur as a primary tumor in the liver, and there are cases of patients who had yolk sac as well as had hepatoblastoma, very rare but reported. So whenever the whole tumor representing glandular elements, just there is no harm to add the SAL4 and to add PLAB, because yolk sac tumor will have high alpha-fetoprotein as the majority of hepatoblastomas. The other thing to keep in mind, again, when we are dealing with limited biopsy, and most of it, if not all, is showing teratoid features, is that teratoma can occur in the liver of young children. However, teratoma tends to display a more diverse tissue components. So it will have like skin, sebaceous glands, and more than that, it will have this organoid arrangement. So these different diverse tissue are actually organized a feature that would not be present in case of hepatoblastoma. Just two things to keep in mind when dealing with teratoid features. The next parameter to report on the CAP protocol for resection is preoperative treatment. So whether the patient have been given preoperative treatment, and in most cases it will be chemo. If any treatment given will be a chemotherapy. In cases of resection, the treatment effect is optional to report or not, but it's highly encouraged. The chemotherapy can induce several changes in the tumor and in the specimen. It can produce replacement fibrosis. It can bring a lot of macrophages, and certainly it can do tumor necrosis. The percent of tumor necrosis, though optional to be reported, is highly encouraged, and the reason for that, because answering this will give an idea about the tumor response to the pre-treatment chemotherapy. So it will give the oncologist additional information of how the tumor responded to the pre-chemotherapy. In general, chemotherapy leads to eradication of the embryonal pattern, and there will be a more prevalent osteoid-like foci. Chemotherapy can induce tumor maturation and differentiation. So sometimes the biopsy will show less mature component, but on the resection, the residual components looks more mature, and this could be chemotherapy-induced maturation. There are reports to suggest that the presence of any embryonal component, the amount of osteoid-like foci, intravascular invasion, amount of mitosis within the epithelial component, as well as tumor necrosis, do have impact on the patient prognosis and outcome. This is still to be determined, it's still not solid, but there are some suggestion that this impact the patient prognosis, and thus these features, along with any small cell undifferentiated component identified in the resection, have to be reported, because these may impact the patient prognosis. Very encouraged to be reported. The other thing that may be seen in those specimens that are post-chemo resection is sometimes at the interface between normal liver and the tumor nodule, sometimes there is bile ductular proliferation. This has to be differentiated from cholangioblastic type of hepatoblastoma, which is another pattern, another epithelial type. The cholangioplastic tend to be arranged in tubules and glands, and the cells tends to be high cuboidal or columnar. They have a high NC ratio, and certainly the tumor looks very much similar compared to the reactive bile ductular component. If any doubt, beta-catenin immunohistochemistry is very helpful because the tumor will show nuclear positive staining for beta-catenin, while the reactive bile ducts will show only membranous staining for beta-catenin, and the nuclei will be negative. The next item in the CAP protocol to be reported upon is margin. This is obviously to be reported upon on resection only. Things to keep when reporting on margin: that the transection margins of a partial hepatectomy may be quite large. And in these cases, it's encouraged to consult the surgeon to determine the critical foci that require microscopic evaluation. In general, when encountering a positive margin on gross examination, microscopic confirmation is mandatory. If the margins look negative on gross examination, then sampling from the closest margin to the tumor nodule is sufficient. Thing to keep in mind that negative margins of resections are important to be reported on because patients who underwent rescue transplants of incompletely resected tumors have shown to have inferior outcome compared to patients who underwent transplant as the primary surgical therapy. So, when dealing with the resection margin, as with any tumor, can we assess it or not, and whether it's involved or not involved with the tumor? If it's not involved, we'll name which margins are these. If it's involved, we'll say the distance from the closest nodule to the tumor, and we'll specify the margin. When dealing with multiple tumor nodules, then the distance will be recorded as the nodule closest to the margin, the nearest tumor nodule to the margin. That's the distance we will record. For capsular surface, similar things. Can we assess it if the specimen is intact, so we can assess the capsular surface or not, and whether it's uninvolved by the tumor? And again, we give the closest distance to the surface, and if it's involved, we'll mention. The next parameter in the CAP protocol is lymphovascular invasion. This is to be reported on resection specimen only. We can see the plus sign, meaning that's optional, but it's really very highly recommended. Thing to keep in mind that to call something positive lymphovascular invasion or positive vascular invasion, the vessel invaded should be outside the tumor nodule, so at the periphery of the nodule, shouldn't be inside the nodule. Usually, the tumor component identified in an area of vascular invasion will show embryonal or more aggressive tumor phenotype. There are studies to suggest that vascular invasion may warrant chemotherapy adjuvant to prevent recurrence and spread. Large vessel invasion is proved to be associated with worse patient outcome. However, microscopic vessel invasion may carry the same worse prognosis, but need to be studied more to confirm, so it may carry. One thing to keep in mind, large vessel invasion may preclude the primary, may be one of the causes that precluded primary resection, and may be the cause why sometimes why a biopsy was given up front. On the CAP protocol, we differentiate between macroscopic and microscopic invasion for the reasons I've mentioned. For the microscopic, is it present or not, or we're not sure, so cannot be determined. And for the macroscopic, because it's seen, we may be able to identify if that vessel is a portal vein or hepatic vein, and certainly when a question is very helpful to consult the surgeon and to correlate with the imaging as well. The next parameter in the CAP protocol is regional lymph nodes. These lymph nodes include the hepatic lymph nodes, which will include hilar lymph nodes, hepatoduodenal ligaments lymph nodes, and lymph nodes around the hepatic portion of the inferior vena cava. In general, lymph nodes will be received with a resection specimen or a transplant or an explant specimen. If a regional lymphadenectomy specimen is performed, usually it yields 3 or more lymph nodes. The reporting will be as with any tumor, no lymph nodes submitted, or there are lymph nodes submitted. If so, the number will be given, and then how many of them were involved. We specify the site, whether hilar, hepatoduodenal, or caval. Additionally, in hepatoblastoma, we specify the histological type. Because of this diversity of the tumor, we specify the histological type of hepatoblastoma, the pattern that we have inside as lymph nodal metastasis. The next category in the CAP protocol, obviously, on resection only, is presence of distant metastasis. We say it's present or not. We specify the site. Lungs tend to be the commonest site for distant metastasis, and again, specifically for hepatoblastoma, we specify the histological type. So what pattern? If it's epithelial, what pattern of epithelial type we have in as the metastatic deposit? Things to keep in mind that comment on distant metastasis on the synoptic report by pathology is required only if confirmed pathologically. In rare cases, a biopsy of metastasis may be performed and may be necessary. In these cases, the histological classification will be according to what's in the liver. So we don't classify the tumor according to the histology present in the metastasis. We record what's in the metastasis, but the histological classification will remain the same as what identified on the liver specimen. Metastatic sites are common to show more aggressive histological pattern as empyrion, small cell undifferentiated, macrotrabecular, and pleomorphic patterns. Occasional metastases resected post-chemo may show the effect of chemotherapy. Thing to keep in mind that inferior phrenic lymph nodes and any lymph node distal to those identified at the hepatic region, so distal to the hilar, hepatoduodenal ligament, and caval, are considered as distant metastases, although they are lymph nodal metastases, but because they are further than these sites are considered as metastases. Presence of distant metastasis is a general contraindication to primary surgery, including transplant. And it may be, if we cannot do the upfront resection, then the pathologist will receive the biopsy prior to any treatment. In the coming 2 slides before we start with the staging, we'll speak about an anatomical classification system called Cono classification, because it will give us idea about the pretext and about the surgery that the surgical procedures that the surgeons use. So the Cono classification is a classification system of the liver anatomy. It divides the liver into 8 functionally independent segments. So each segment of the liver have its own inflow, outflow blood supply, as well as its biliary drainage. The 8 segments are from 1 to 8. The right lobe tend to include segment 5 to 8. The left lobe will include segment 1 to 4. The right lobe will be further divided into 2 different parts that we call them sections, and this is where the word segmentectomy comes from for the surgeon when they resect. Will be divided, so the right lobe will be divided into 2 parts, a right posterior and a right anterior. The right anterior will include segment 5 and 8, and the right posterior will include segment 7 and 6. The left lobe will further be divided into left medial sector or section that will include segment 4, and the left lateral will include segment 2 and 3. In general, if the tumor spares the left medial sector and the right anterior segment, so if these segments are not involved, then this tumor can be treated by primary resection. The general rule, like tumors sparing these left medial and right anterior sectors can be resected. So again, this is just to give idea. So the right lobe includes segment 5 to 8. So on the upper picture on the left, everything blue, if taken by the surgeon, then this is a right hepatectomy. But if the surgeon include segment 4, which is supposed to represent part of the left lobe, then the surgery will be named as extended right hepatectomy. Similarly, on the left lobe is supposed to include 1 to 4 segments. So if they are removed by the surgeon, then it's left hepatectomy. But if the surgeon included segments 5 and 8, then the surgery will be extended left hepatectomy because it's included 5 and 8 that belong to the right lobe. The pretext is a radiological system that's used to assess the tumor extension within the liver and with extra within the liver and in extra hepatic locations as well. The pretext is based on cross-sectional imaging assessment of the extent of tumor involvement. It divides the liver into 4 parts, so 4 main sections. The pretext assess the tumor involvement before any chemotherapy, so before therapy. There is another system that's called post-text, which stands for post-treatment extent of disease, and it assesses the liver involvement, but in response to therapy. So this is when the parameters are assessed after chemotherapy, usually by the 2nd dose of chemotherapy. So the pretext divides the liver into 4 equal parts, and according to the number of the parts that are contiguous and not involved with the tumor, a pretext number, either 1 or 2 or 3 or 4, will be assigned. So with pretext 1, what we have is that we have 3 contiguous parts of the liver not involved with the tumor. So the tumor is only involving 1 part of the liver and 3 next door contiguous not involved. This is 1. When we come to pretext 3, for example, we have the tumor involving the liver with no 2 adjoining part, no 2 contiguous part of the liver not involved. So that's pretext 3. When we come to 4, then all the liver is involved. We don't have any part that's not involved by the tumor. Pretext is further annotated to include this extra hepatic parenchymal extension. So we have a V component that denotes if the tumor reached the hepatic vein, P component for portal vein, E for extra liver, so if diaphragm, stomach, the adjacent organs, R for rupture, F for multifocal, and M for distant metastasis. It even goes more than that, for example, for the V or the P, it gets even subdivided. So whether the tumor is encroaching or actually infiltrating the vena cava have different subcategories in. And the pretext is the system that's used by all international, by the COGAN or international group to assess the tumor extension. And that's one of the decisive factor whether the patient will have upfront resection or not. The next parameter in the care protocol is to report on the staging. This is optional but encouraged to do. So for stage 1 means that the tumor is limited to the liver with no microscopic or gross residual in the patient. Stage 2, when the surgeon take all the tumors, so there is no evidence of gross residual tumor in the patient, whether at the hepatic margins or the extrahepatic margins in case of explant, but the pathologists identify a microscopic residual tumor. Cases of intratumor spill are also included as stage 2. Stage 3, when already there is a macroscopic evidence of residual tumor at the resection margins. So the surgeon knows that there is some tumor left behind. Or those cases in which the hepatic lymph nodes are positive. The stage 4 means there is distant metastasis, and this is irrespective of what's in the liver. The liver can be all the tumor out, no gross remainder of the tumor, but if we have a metastasis, then this is stage 4. In this slide, I just added to try to tie between the histology and the staging. So hepatoblastoma, when it's stage 1 and 2, which is about a third of patients, so 20 to 30% of patients will be presenting on stage 1 or 2. The really decisive factor for the overall survival of these patients is the hepatoblastoma histology. It's the epithelial pattern we encountered. So it's very important for the pathology on those one to sort. For example, if a well-differentiated fetal type, the mitotically inactive type, was identified and all the specimen is formed from it after extensive sampling, it was found that the 3 to 5 year overall survival is 100% even without a chemotherapy. Just for the well-differentiated fetal type, I want to emphasize that this diagnosis is done only after resection and without giving a chemotherapy. So if the entire biopsy is composed of this pattern, the possibility of primary resection should be advocated to minimize the need of chemotherapy. And if indeed the resected tumors appear histologically uniform with no other identifiable pattern, and this in low stage 1 and 2, then the patient, and the margins are negative, then the patient do not require any additional therapy. So the patient do not require any chemotherapy. The current Children's Oncology Group study is treating stage 1 well-differentiated fetal hepatoblastoma with low mitotic rate with surgery alone. And the reason for that, because we can see even without chemotherapy, 100% of patients have a 3 to 5 year overall survival. When the histology is not a well-differentiated fetal type and is not a small cell undifferentiated, and the patient still stage 1 and 2, the overall survival, 3 to 4 year overall survival, is 90 to 100%, but patient is given adjuvant chemotherapy. So you can see how the histology influenced the treatment of the patient and somehow the prognosis. When a small cell undifferentiated component identified, the 3-year survival rate drops to between 40 to 70%. So it's very crucial for the pathologist, particularly in these low stages, to really estimate the percent of each component and whether it's present or not. Stage 3, usually majority of cases will present at this stage and will account for 50 to 70% of cases. In these cases, 3 to 5 year overall survival is less than 70%, and for stage 4, which account for 10 to 20% of cases, the 3 to 5 year overall survival is very variable and range from 20 to about even 60% in some reports. This slide I just put because sometimes, like we're dealing with the synoptic reporting, it's putting all this parameter in, but sometimes, at least for me, like on the diagnosis, what should I write? So I just put it it's optional to go this way. A pathologist report their diagnosis according to their comfort and according to what they were trained to do. I'm showing what I tend to do. So I'll say the liver mass is it right or left or both, depends on what the surgeon or how the specimen was labeled and given to me. The operation, I'll code the operation done, whether it's a segmentectomy, extended lobectomy, explant, the weight of the specimen, the maximum dimension of the tumor, the types, the histological types. The most important is the epithelial. So I'll quote all the epithelial components I had and the percent of each component. The stage, if I know it, and if I have the imaging and the clinical information for whether the tumor is solitary or multifocal, and the margin status. If it's negative, then I'll say the distance. The next parameter on the CAP protocol is to report on additional pathological findings. This is required to be reported whether in a biopsy and resection, and it just says what's on the background liver. Cirrhosis, iron overload, hepatitis. The next parameter in the CAP protocol is to report on the serum alpha-fetoprotein levels. This is required in the biopsy protocol as well as the resection protocol. Alpha-fetoprotein is a useful indicator for hepatocellular neoplasia. It's elevated in about 90% of hepatoblastoma. But to keep in mind, it's not specific to hepatoblastoma because about 60% of hepatocellular carcinoma will have it positive. Yolk sac tumor will have high alpha-fetoprotein levels. Even benign tumors as mesenchymal hamartoma, hepatic hemangioma, hemangioendothelioma can be associated with high alpha-fetoprotein. Thing to keep in mind that usually with these tumors that the main component is small cell undifferentiated, they tend to have a normal or not increased levels of alpha-fetoprotein. Low levels of alpha-fetoprotein below 100 nanogram per milliliter are poor prognostic indicators, because large subset of these tumors can have a small cell component. But there are reports to show that some tumors that are almost entirely formed of fetal type can have a low alpha-fetoprotein levels. So in certain instances, it can be associated with a few cases that have fetal pattern. Lack of significant decrease of alpha-fetoprotein levels with treatment may predict a poor response to chemotherapy. So certainly alpha-fetoprotein is very helpful to assess the chemotherapy response when the chemotherapy is given upfront. It's very helpful to see this decline to indicate that the tumor is responding to chemotherapy. The other thing that's useful is by imaging to assess the change in the tumor size as well as the post-text. The one before the last category in the CAP protocol is ancillary studies, and this is required to report in biopsy and resection. The minimum stains to do is INI, glypican-3, and beta-catenin. The INI will be reported whether it's retained, so it's positive, or it's lost, so it's negative. The glypican-3 will be reported as positive and negative, and the pattern of staining has to be reported, and I'll show why in the coming pictures. Beta-catenin staining is interpreted according to nuclear expression. So if the nuclei are positive, then it's positive. If the nuclei are negative, then it's negative. It doesn't matter what the membrane show, what the cytoplasm show. If membranous or cytoplasmic staining but no nuclear, then it's negative. There is also room to do additional immunohistochemistry stains because some people utilize with hepatoblastoma, cyclin D1, glutamine synthase, and there are room to use these stains to differentiate between different patterns a bit, and as well to differentiate between normal liver with those very well differentiated patterns. There's also additional stains if what I have is a limited biopsy with this intestinal component questioning a yolk sac, for example, then I'll do my cell4 and other battery to exclude this diagnosis or to assess for this diagnosis. So there is room to do other stains. This is the well-differentiated fetal pattern, and we can see with the beta-catenin there is membrane staining, so it means that the beta-catenin is negative because I don't see the nuclear staining. The well-differentiated fetal pattern tend to show is positive for glypican-3, but the staining tends to be fine, granular, and limited to the apical portions of the cell, or what people call pericanalicular staining. This contrasts to the embryonal pattern and the crowded fetal type, which tend to express nuclear staining for beta-catenin, but the glypican-3 will be positive, but in more diffuse and more coarse granules. The small cell undifferentiated component, and I'm putting a picture of the common scenario to see it, is that it will be these islands that can be easily missed by the pathologist. They tend to be negative for glypican-3. They show nuclear positive expression with beta-catenin, and the INI is mandatory to be done. In a subset of cases, the INI generally, in a small cell undifferentiated, the INI will be retained and positive, and in a subset of cases, it may even show more dense staining compared to the surrounding cells. This is again another case with a small cell undifferentiated component, and we can see that with the INI, is still the staining is retained, but it's not as strongly positive as in the previous picture. Evaluation of small cell undifferentiated component with an INI stain is crucial, particularly if the small cell undifferentiated component form a significant portion of the biopsy. Any loss of the INI1 in a small cell undifferentiated component may warrant reclassification on a review as a malignant rhabdoid tumor with a different children's oncology group treatment protocol. And then the last parameter in the CAP protocol is optional to put a comment. This is present in the biopsy and the resection, and this is because if anything that the pathologist think is important to convey to the clinician, but is not captured by the synoptic reporting, this is where to report these things. At the end of the presentation, I would like to thank the CAP protocol, from which we quoted all the protocol through this talk. Special and very grateful and special appreciation to Dr. Ranga, who helped me during my fellowship training and taught me a lot about hepatoblastoma, as well as for providing the majority of the images that I utilized during this talk, as well as answering some of the questions that I had on the protocol. Many thanks to Dr. Magil Reis and Dr. Shihata, who helped me as well and provided me with some of the pictures and images I used in this talk. Special thanks to Dr. Dananasi for giving me the opportunity to present this webinar and for his kind introduction. I would also want to thank Ms. Jordan, Sony, Mohammed for all their help with the webinar, with the technical part of it, with the advertising. I would also like to thank Monsieur Desrochers, our path assistant, for scanning many of the slides for which I was able to take pictures that were incorporated in this talk. These are just few references that are very helpful, in my opinion, to understand the pathology of hepatoblastoma. And thank you.
Well, thank you very much, Dr. Demellawy. That was excellent. It was a very scholarly and at the same time practical presentation for both pathologists and clinicians. We really appreciate all the information that you were able to convey to us today. And so now then I would like to open the field for questions. any of the participants, if you have any questions that Dr. Demellawy would be in a position to answer, please forward them and put them in the Skype, and I will present them to all participants. So I am looking at questions, and while we are waiting, if you don't mind, I was taking notes as you were going through your presentation, so I will allow myself to start with a question. Practicing as a pathologist, I got curious, how do you assess specimen margins if the resection comes in multiple pieces?
Ideally, on a resection, the margins will be intact, so we can ink it and able to assess on those cases when it comes as multiple pieces, unless it's one piece and just like taken separately, so put in fuss and assess, but as multiple pieces, very difficult to assess, especially if there is no relation with to the tumor nodule. I mean, sometimes it's helpful when you see the cautery site. However, if it's in pieces, you're not sure if it's represented true margin or not. So I reported with the comment cannot be assessed because it's received as multiple pieces. But then if I see tumor at the cautery, I'll mention that I'm receiving it in separate pieces, separate from the resection, from the tumor nodules, and it's not specified as margins. So because you can receive it as one piece or as two pieces, but specified as margin, and but if communication with the surgeon says this is the margin, just shaved margin, then it can be assessed, provided the surgeon can highlight which side was the tumor and which side is the margin of the piece, and you can embed accordingly. But that's not the ideal way. The ideal way is to receive the whole specimen intact, ink your margin, able to assess the distance. That's the ideal way to assess a margin. Does this answer your question?
Yes, thank you. So no, I was just wondering in situations where the specimen is not straightforward, then I suppose interaction with the surgeon is of paramount importance for orientation.
Absolutely.
Okay. Anybody else would like to submit the questions? Well, in the meanwhile, while we are waiting, if you don't mind, another question crossed my mind. Can you tell heterogeneous regions in a mesenchymal hepatoblastoma on imaging?
So the bone one can be captured, because with these amount of osteoid, and sometimes there's calcification, certainly this is something that the radiologist can see. And it's actually one of the things that's encouraged with the pathologist, even if you don't see it particularly in dealing with the biopsy, but you see imaging, they say there is bone formation within the tumors, to put this note that this may be a mixed epithelial based on what you have on your biopsy, and there may be a mesenchymal component represented by bone as per imaging. So they can see the bone part on imaging. The other component.
I wanted to make sure what is it that how can we correlate what they see on imaging with what we see on pathology. So thank you for answering that. Shali, are there any questions that you might see that I am not available to visualize?
No, I don't.
So,
but
please,
just
let
I
me
don't.
know.
Okay, I don't see any questions. Just a reminder to the attendees that you're automatically muted. And if you'd like to submit a question, it's in the chat area, and you can access that by clicking the bottom left corner. There's a black or white circle with a square to open the chat section. So maybe while we give some people some time to think about that, do you want to read just the closing remarks? And if there are any questions afterwards, we can go back to those.
So we have the line is open until 2:30 or so, if we go to the time limit. So in the meanwhile, then, so on behalf of the Pediatric Oncology Group of Ontario and the Canadian Partnership Against Cancer, as well as the Canadian Association of Pathologists, I would like to thank Dr. Demellawy for a very thorough and comprehensive presentation on pediatric hepatoblastoma today. And for the audience participating, as a reminder, I should mention that both the live and the recorded presentations are eligible for continuing education credits, but you have to request it. So in order to request your certificate of participation, you have to provide your name and email address at the link which was included with the session notice. And in that same location, you will also find a session evaluation form, which is optional, but we would strongly encourage you to complete it. Now, the information that we collect through these evaluations are intended to help us ensure that these sessions will continue to be informative and relevant to your particular practice. So we really do appreciate your feedback and suggestions. And so I encourage you to see the session notice for more information. And any questions that have come up in the meanwhile?
No, I don't see any.
Okay. Well, if you don't mind, I might have another one if I can fill in the time for a moment here. What are most common sites of distant metastasis?
The commonest will be the lungs, but there are cases in which can have a brain metastasis. But the commonest is the lung because of the drainage through the portal vein, then hepatic veins, then it will be captured by the lung as the commonest site for metastasis.
Okay, and just out of my personal curiosity, have you ever seen or read reports about macrotrabecular hepatoblastoma and hepatocellular carcinoma occurring in the same lesion?
So as I mentioned, like the macrotrabecular type, when first described, it required 20 cell thick plates. And this is very unusual for hepatoblastoma. On further review, it became apparent that there is a subset of these cases that actually represent hepatocellular carcinoma rather than a hepatoblastoma. And this is why the term got revised more to become more than 5 cell thick. There is also a classification by Dr. Zimmerman in his papers. He mentioned that to divide them into 2 types, those that have the cells showing fetal and embryonal morphology, and those that resemble hepatocellular carcinoma, right? So you can see the overlap. So even on cytological level, they are divided in 2 types, but this is not yet used in reporting and still under study. So when it's seen as macrotrabecular, it's just recorded as macrotrabecular, but certainly it overlaps with hepatocellular carcinoma.
Okay, yes, and that's very useful for the pathologist to know. Thank you very much. And again, as I was listening, I was scribbling just one last thing quickly. If a tumor is deemed unresectable, all 4 sections are involved, do we still get a biopsy from the tumor to confirm the histological diagnosis?
Yes. So the COG policy is to always have a biopsy. So the first thing is to try to do resection, right? If not feasible because of high stage, as the case you're asking the question, then upfront biopsy prior to any chemotherapy will be done. The value of this biopsy is that it will capture the true components of the tumor. It won't show you, because after chemo, many of these cases will end by resection, right? But the tumor there will show the post-chemotherapy effects. So it can show tumor maturation. It can show no embryonal component because embryonal tend to be radiosensitive, right? On the resection. But it doesn't show you the true tumor component. So the biopsy have the advantage for that, and certainly it's mandated to be done before any chemotherapy. The problem with the biopsy is that depends on its size and depends on its representation, it may not capture all the patterns that present in hepatoblastoma. You can see we have different patterns, and these patterns tend to intermingle closely together. So it might capture some of the patterns, but not all.
Okay. Well, good. Thank you. And one last chance for participants to... Okay, here is a question.
Well, we had Rito Barshinger said that your presentation was great, and thank you for the presentation.
Thank you. Thank you so much.
Well, we can certainly echo that. Thank you so very much, Dr. Demellawy, for your excellent presentation today. We are that much smarter for it. So I really appreciate the time and effort you put into it, and so we are that much better educated. So with that, I will bring this webinar to a closure, and until we meet next time. So thank you very much again, Dr. Demellawy.
Thank you so much for giving me the opportunity to present. Thank you.